Hello, my name is Dr. Ukiri Richard. This podcast is continuing on basic cardiology. We shall talk about persistent chest pain with nausea today. A 78-year-old man was brought into your medical emergency with suspicion of an acute coronary syndrome. He complains about persistent chest pains since 3 hours. The pains are actually like pressure, and there was nausea. The patient was in your hospital 8 years ago in the endocrinology department to control his diabetes. Then his ECG and echocardiography was normal. Comorbidities are metabolic syndrome, including insulin-dependent diabetes mellitus, and also peripheral arterial vascular disease involved in leg Fontaine stage 2A. You did an ECG, including the right chest lead, which shows for atrial fibrillation with heart rate of about 80 per minute. Axis is sagittal, S1, S2, S3. There was ventricular extrasystole and a maximum of 0.2 millivolt ST depression in V1 to V5 descending in nature, as well as pre-terminal negative T waves in V1 to V4 and marked U waves in the chest leads. In V7 to V9, you saw a slightly elevated ST segment, which actually begins from the arrow wave. My question is, what is your diagnosis and what are you going to do for this patient? Well, according to the presentation of the retrosternal chest lead, that is V7 to V9, we have an ST elevation myocardial infarction in stage 1, which has crossed the 0.05 millivolt line. Considering the congruent ST segment depression in V1 to V4 and the persistent symptoms, I really do a cardiac coronary examination, that is a cath lab examination. While preparing for the cath lab, you give oxygen as 2 to 4 liters per minute, beta blocker, either 50 milligram oral metoprolol or 5 milligram intravenously. Please check out for bradycardia, AV block, and signs of heart failure. Also, you give aspirin 250 milligram intravenously. You also give either clopidogrel 600 milligram loading dose or prasugrel 60 milligram loading dose. If possible, you still give anticoagulation, for example, heparin 5000 international and units. Check for the vital parameters, and you give nitroglycerin when there is no right ventricular involvement. Generally, my question is, how does a back wall myocardial infarction in ECG manifest? Well, the answer is an inferior infarction in region of the branch supplied by circumflex branch or the right coronary artery. You have typical ECG changes in 2-3 AVF. If it is inferolateral involvement, also V3 to V6. If it involves the right ventricle, for example, by stenosis of the proximal right coronary artery, the ST elevations are seen in VR3 to 5. If the infarction is strictly posterior, that is the true posterior, for example, stenosis of the distal posterolateral sinister branch, you find a arrow to S relationship greater than 1 in V1 with high arrow wave and T waves in V1 plus V2. These changes are usually due to loss of amplitude in the retrocardial leads in V7 to V9. So, you did a cardiac catheterization and you found a severe coronary vascular disease involving, which shows a high-grade stenosis, distal main stem stenosis, and also an ostium occlusion of the great marginal branch. ROCA has a less than 70% stenosis. The patient refuses to have a bypass because he's a Jehovah Witness. Because of that, you did a recanalization with reopening, revascularization, and stenting of the marginal branch, and also PCI, that is primary coronary intervention of the main stem under IVUS control. IVUS is intravascular ultrasonography, and the lesion was thereafter handled with a drug-eluting stent. In the ventriculography, you saw a moderately reduced left ventricular systolic function and also a moderate mitral valve insufficiency. The left ventricular end diastolic pressure was 22 millimeters of mercury. My question now, what scores do you know, or what score systems do you know that can predict the operative mortality of patients with unstable coronary vascular diseases? Well, here I can talk about the Euro score, or there's ones you call the PASONET, PAROSONNET, PASONET score. So the patient was treated and made thereafter with medicines on inpatient basis and discharged into for rehabilitation. 5 months later, the patient was brought again into the medical emergency due to progressive shortness of breath within the last week, and the patient was unable to sleep because of shortness of breath last night. The oxygen saturation without oxygen was 85%. The blood pressure was 140 to 75 millimeters of mercury. There was jugular venous congestion, peripheral and central cyanosis. The heartbeat was irregular and the heart rate there was tachycardia in the heart frequency. There was a 3/6 hollow systolic murmur around the left sternum and apex with radiation to the left axilla. Also a loud second heart sound. The breath sounds were reduced basally, and they were moderate to high frequent crepitations bilaterally. Respiratory rate was 27 per minute. There were also significant bilateral peding edema. What investigations will you do now? Well, immediately I will do a 12-canal ECG, including right and retrocardial leads. A blood gas analysis will be necessary to monitor the oxygen saturation. In the laboratory test, I will check the electrolytes, glucose, renal function, liver function, food blood count, cardiac markers, coagulation, and D-dimer. I'll do a chest x-ray and echocardiography. What do you think about adding BNP or NT-proBNP? BNP is brain natriuretic peptide. Answer: the physical examination and the history as indicative of an acute congestion insufficiency. But don't forget that we should also have differential diagnosis in mind, like pulmonary embolism. BNP and NT-proBNP as markers for myocardial wall tension have high negative predictive rate value to exclude an anticipated heart failure. But sometimes you can have negative values in special conditions, for example, in acute myocardial infarction with pulmonary congestion. In stratifying heart insufficiency, that's heart failure, BMP have proven to be useful. Repeated values of over 400 picogram per milliliter for BMP and over 2000 picogram per milliliter for NT-proBNP makes a heart failure very unlikely. Now the ECG is ready. There was sinus rhythm with a rate of 100 per minute without repolarization disturbances or signs of ischemia. And the X-ray was also ready, where you could see a globally enlarged heart with not well defined hilli. The tracheal angles were widened. There were large scattered diffuse shadows, and the baseline of the lungs were not clear, especially on the right, which are actually signs of pleural effusion that are running cranially because the patient is lying down. The peripheral vessels were also prominent. Well, you cannot say anything about the infiltration because of the cloudiness of the X-ray. But just note that an optimal chest X-ray should be done in 2 axes. This is usually difficult or not possible in seriously ill patients. But here you have to make sure that the angles are well seen in the chest X-ray. So the blood gas analysis showed a pH of 7.14, carbon dioxide partial tension 45.3, oxygen partial pressure 67.2, bicarbonate 15.1. The base SS was minus 13.6, sodium 145, potassium 3.6, chloride 108. How do you interpret this? Well, there's a significant metabolic acidosis that is not compensated for respiratorily and cannot be compensated for respiratorily. The oxygen take-up in respect of the serious, the oxygen take-up is too low. Despite a relative hyperventilation with a respiratory rate of 27 per minute, you still have a raised PCO2 and a low PO2. In this case, the trigger for the raised respiratory push is the alveolar pulmonary edema. This is causing problems with sufficient arterial oxygenation and simultaneous CO2 give off. The significant metabolic acidosis is most probably due to the hypoxemic phase with consecutive tissue oxygen insufficiency before presentation in the hospital. So your patient, thank you for that. Now your patient is getting very dyspneish. The extremities are getting cold and cyanotic, and due to the already applied diuretics, the patient started making urine after some time sufficiently. What other measures will you undertake? Yes, immediately I will do the following measures. 1, I will position the patient in cardiac position, that is half sitting position. I'll give oxygen through the nose, reduction of stress and angiolisis with benzodiazepine, for example, diazepam or opiates, for example, morphine or fentanyl. I'll give an afterload reduction, sinker, through nitroglycerin while considering the systemic blood pressure. I may give additional diuretic depending on the clinical state, that means the amount of urine passed per hour, auscultation finding, and blood pressure. And I will also take the patient immediately to the intensive station. So you have taken the patient to the intensive station. What criteria will determine if you will do a ventilation or not? Well, first of all, I would like to know if the patient has anything against ventilation. That is one. Two, I will check for indication and contraindication for non-invasive ventilation, for especially the pH and comorbidities. And I will also check for signs of clinical exhaustion hypoventilation, which are reducing pH, reducing PO2, reducing rising PCO2, and also signs like dyspnea, cyanosis, tachycardia, hypoventilation, heart rhythm disorders, consciousness disturbances, gasping, apnea, blood pressure fall or shock, non-reactive pupils, bradycardia or asystole. And the corresponding treatments, if by dyspnea you give a cardiac position, if there's cyanosis you give oxygen, if there's tachycardia you sedate, if there's hyperventilation you give diuretics or nitrate, if there's heart rhythm disturbance you may do a cardioversion or do medical rhythm stabilization with medicines. If there's loss of consciousness, you intubate and do a narcosis. Also, you still do that if there's gasping. Do controlled ventilation. If there's blood pressure fall, you give catecholamine, and in some cases you may need to do reanimation. Okay, now, so as to exclude a restenosis in the areas you already treated, revascularized with stents previously, you did a cardiac catheterization, which was difficult for the patient to tolerate lying down. So because of the progressive respiratory insufficiency and exhaustion, you intubated the patient and mechanically ventilated the patient. Your lab results just came out. The pathologic findings were lightly elevated troponin from 0.07, normally 0.03. CK was a normal range, creatinine 1.4, glucose 150, BNP 3041, CRP was normal, gamma GT was 115. In the echocardiography, the left ventricular systolic function was moderately reduced, and there was hypo/akinesia, basal, mid, posterolateral, as well as apical, front wall, and mid-apical septum. Left ventricle was globally dilated. The end systolic diameter was 52 millimeters. Left atrium was also dilated. The valves were sclerosed. There was deepening of the mitral leaflet from the valve level anteriorly. You also noticed restriction of the posterior mitral valve leaflet due to axial displacement of the posterior papillary muscle. In the colored duplex imaging, CDI, there was a very prominent vena contracta. There was a great pendule volume with high early diastolic transmitral flow speed, as well as slow systolic pulmonary flow. That is pulmonary venous flow. There was also significant pressure stress on the right ventricle with a maximum pressure gradient of 58 millimeters of mercury plus central venous pressure across the lightly insufficient tricuspid valve. How do you explain this dramatic severe mitral valve regurgitation? Which forms of ischemic mitral valve regurgitation do you know? Well, when you look at the history, diabetes, angina pectoris, head catheterization, a chronic ischemic mitral valve insufficiency is most likely. The following etiologic variations of ischemic mitral valves are known. 1. ischemic mitral valve insufficiency without rupture of the papillary muscle. 2. Partial rupture of the papillary muscle. And 3. Complete rupture of the papillary muscle. In the first case, the ischemic mitral insufficiency without rupture of papillary muscles, this is caused due to results as from ischemia, for example, after infarction from right coronary artery or circumflex branch. There is change in the geometry of the left ventricle, which causes a displacement of the posterior papillary muscles towards the outside and posteriorly, that is tethering hypothesis. This alone, and also or in combination with a reduced left ventricular global contractility as a closing force hypothesis, can lead to an insufficiency in the valvular closure. This form of ischemic mitral valve insufficiency is usually referred to as chronic ischemic mitral valve insufficiency. In the second case, which is the mitral insufficiency with partial rupture of the papillary muscle, this is caused due to a direct papillary muscle ischemia and a consequent necrosis. The incidence for this complication is highest in the first week after myocardial infarction, and the posterior papillary muscles are 5 times more affected than the anterior. The severity of the insufficiency will depend on the localization. This almost always leads to an acute mitral insufficiency. It has a high lethality, and an immediate operation is indicated. Don't forget about the organic mitral valve insufficiency, but in this case, because of no history of endocarditis and a good echocardiography 10 years ago, it makes it very unlikely. So let's come back to your coronary angiography. The coronary angiography showed a 50% restenosis in the stent implanted in the distal part of the main stem. The stent implanted in the marginal branch was in order, and there was light progression in the ROCA that is now presenting with a high-grade stenosis. And in the ventriculography, you saw the severe mitral insufficiency. What therapy will you suggest? I think it's very clear. Because of the severe mitral insufficiency and the coronary heart disease, I will recommend a bypass operation and mitral valve replacement or reconstruction operation. In brackets, undersized ring annuloplasty and eventually left ventricular remodeling. Until the operation is carried out, the patient has to be in the intensive station. And before the operation, I would like to do a transesophageal echocardiography to do an exact presentation of the intracardial valves and morphology. Additional information. Presently, there are very different existing percutaneous annuloplasties measures through coronary sinus or transventricular. These seem to be promising good, but they are still undergoing clinical trials. For example, the Accor, Edward, Monarch System, Quantum Core, Mitralink. Also, the mitral clips via transeptal abscess is also in trial. In this our case, after the patient was recompensated, the patient still refused an operative intervention because he is a Jehovah's Witness and he would not like to take blood transfusion. So, in this respect, one of the above mentioned annuloplasty, percutaneous annuloplasty, was undertaken. The ROCA was stented And the restenosis in the main stem was treated with a medicated balloon. Thank you.